Welcome, everybody, today to the Fracture Files Silver Linings for Geriatric Fractures podcast. We're really excited to have a guest speaker here today. We have Dr. Jamieson. She is an assistant professor at University of Colorado, a foot and ankle orthopedic surgeon, and who specializes in all things foot and ankle. We're really excited to have her join us today about how she thinks through her geriatric fracture foot and ankle patients. Before we get started, I'm Carmen Quatman. I'm an associate professor at Ohio State University and current president of the International Geriatric Fracture Society. This podcast was started to help provide education, innovation thoughts, and kind of growing the concept around how we should provide best care to our geriatric fracture patients. So with that, I'm going to go ahead and get kick-started and say, welcome, Dr. Jamieson. We're really excited to have you as part of our team today, and can't wait to see the types of things you're doing in your practice.
Yeah, thanks so much for having me. It's great to be here. It's an important topic, so excited to talk about it.
Yeah, that's great. So just a little background about foot and ankle and our geriatric patients. I just want to open up with a question around the thought process you have when you have a patient show up with an ankle fracture who is maybe in the 65 plus range or demonstrates some chronological or physiologic signs that might be more towards that geriatric or fragility fracture patient.
Yeah, so first of all, we're very fortunate in Colorado. We have very healthy, active elderly patients. A lot of my 65 plus patients are more like 45, just in their activity level, but they often still, even though they're active and healthy, they still carry a lot of these comorbidities, diabetes, peripheral vascular disease, osteoporosis, those sort of things. So first of all, when I'm evaluating an ankle fracture, especially in someone 65 or older, always look at bone quality. And then, I am more tempted to treat some of these non-operatively than I maybe would in a like 20-year-old. If it's amenable to non-operative management, if it's well aligned, if it's non-displaced, and especially if I feel like I can let them weight bear in a boot. Isolated lateral malleolus fracture is without significant instability. I will, if I feel like I can treat them non-operatively in a boot and get them to heal adequately and appropriately, then I will always do that. I think keeping these patients mobile is very important. So first of all, I always try to treat it non-operatively if I can. A lot of these unfortunately need surgery. If they're unstable, I think surgical management is appropriate. And I think there's been good studies that show that a lot of times in these bad fractures in elderly patients, non-operative management can actually carry higher risks than some of the operative management. So I try to get these fixed pretty quickly. If I see a fracture in a geriatric patient, a lot of times they're coming in through the ER. And often in my experience, I found that they'll get admitted just because they have to be splinted, they have to be immobilized, and they don't have the strength, or the ability to maintain that non-weight bearing status. So I will try to fix these while they're in-house, if at all possible. Depending on obviously soft tissue swelling and the soft tissue envelope. But I try to get to these as soon as I can. Just I think the less time they have to be immobilized, the better. So I
Yeah.
try to get them really quickly, and obviously, have co-management with the hospitalist team in the hospital to manage all their comorbidities is super helpful as well.
Yeah, absolutely agree with a lot of that. And I just want to echo and kind of amplify what you started with in the beginning, which was trying to understand the bone quality that you're dealing with. And a lot of the people in our multidisciplinary audience, think about bone quality in many different capacities. And, we talk about like the gold standard concept of using like DEXA scanning and other, more um, potentially objective measures. I personally noticed that I've seen a lot of x-rays, and even looking at the x-ray, I do have some pulse of the type of bone I'm getting into, but I I
Absolutely.
I also feel like I've sometimes been in a surgery, and I wouldn't say I'm surprised, but like there, there's different, almost a different feel to the type of bones that I feel when I get in there, and I try to make sure I keep that dictated in there, but their DEXA scan might be okay. And the quality of bone does not feel okay when I get in there surgically. So I'm just wondering if you have any thoughts about that.
Yeah, absolutely. I always tell patients, when I'm looking at x-rays, I'm like, look, a surprisingly amount of patients have not had DEXA scans and come in and they're, in their 70s or even 80s, and I look at their bone and it looks clear on x-ray. I'm like, like I know this isn't a perfect judge, but I am concerned about your bone quality. And so definitely take that into consideration surgically. I tend to go big with these patients, meaning strong plates, strong fixation, the locking screw technology, which is really great for osteoporotic bone. And it's great to be able to do minimally invasive, or like percutaneous, so small incisions techniques if the surgical or if the fracture is amenable to that. I've used a lot of intramedullary nailing for the fibula in specific situations, which is a really strong construct, great for osteoporotic bone, and all small incisions, so we don't have to worry about wound healing. And I also dictate in my note the quality of the
Mhm.
bone. And it really is. I know it's not a perfect judge, but I always tell the patient afterwards too, like, look, I got in there, your bone was even worse or was actually better than I thought. So I always tell them that. And if they don't have a DEXA scan, I always order it myself. And, talk to them about supplementation with vitamin D and just encourage them to follow up with their primary care, regarding all of that. But it's definitely
Yeah.
something that I take in, and, that I keep in mind and that I talk with my patient openly about.
Yeah, it's so interesting. I'm going to go on a little tangent for vitamin D for just 1 second. People
Yeah.
always have a lot of thoughts around whether we should do calcium and vitamin D supplementation. There was a large, evidence-based trial that came out that talked about they're not sure that vitamin D necessarily prevents fractures. But what's really important to highlight in that extremely well rigorous randomized controlled trial, the missing element to that was that's for patients to develop a fracture, not necessarily the fracture healing portion of it. And so there's a second part to that debate that can sometimes come up about where we do with vitamin D supplementation and fractures and fracture prevention. And one thing I haven't seen come out yet truly is what we need to do about the vitamin D supplementation in my world. Everybody's vitamin D deficient where we live, and so it's a crucial thing that we do think a lot about from a healing perspective. That it's not even about the fracture prevention, but more so about the
Yeah.
supplementation, thinking about the types of nutrients they need to produce healing. So just a side tangent for a second.
Yeah, yeah,
But I
no,
want,
absolutely. I mean, and even here, a lot of patients are vitamin D deficient, and if I'm doing, and I do a lot of obviously bony procedures, fractures being one of them, but fusions and ankle arthroplasty and all those that are, bone quality matters, and I'm always shocked at how many, especially white older females who are the highest risk for osteoporosis, are not taking any supplementation and never have.
yeah, I think it's always interesting to kind of see the spectrum that they're on and have that conversation. Um, I want to go back to the minimally invasive surgery concept for a second, and one, explain a little bit about, you mentioned intramedullary fixation, and you mentioned big steel, plates and things like that. So, just for kind of the more multidisciplinary audience, do you want to explain the concept behind minimally invasive surgery, and then
Yeah,
maybe what an
so
intramedullary construct
yeah, so
is?
traditional open reduction internal fixation of these fractures involves kind of big incision all along, the fibula or the medial malleolus inside of the ankle or the back. Big incision, big dissection, visualizing the fracture, putting everything back together, directly with clamps or a variety of other instruments, and then putting a big plate with various types of screws, stabilizing it. It's a great construct. It's very stable. It's very strong. But especially in elderly patients or patients with diabetes or poor soft tissue envelope for whatever reason, minimally invasive is a very attractive alternative. Instead of having a huge open incision, you can do the reduction closed. So basically, you can put percutaneous, meaning small incision, clamps on the bones and kind of manually reduce them, get them back into alignment. And then through very small incisions, you can insert a device that goes inside the bone, so nothing on the outside of the bone. And that is a great way to stabilize these fractures in appropriate cases. Sometimes they're too displaced or it's too comminuted or in too many different pieces to get a good enough reduction to allow for that. But I think this is a minimally invasive techniques either with intramedullary nailing or just simple screws. So a lot of times these fractures can be fixed with just simple screws. So if the fracture is completely non-displaced, but you want to get them moving a little bit more quickly and you want kind of an insurance policy, so to speak, for these patients to allow them to get moving more quickly, then you can do just screw fixation across the fractures. And that gives a little bit more stability, especially in these osteoporotic or patients with osteoporosis. So that's one technique of using just screws or intramedullary rods to stabilize these fractures, as opposed to the big open incision plating, which again has its role, has its benefit, is definitely necessary in a lot of these. But for the right patient, I think it's a really great tool to have.
Hmm. Hmm. Um, I I think it's really important I always, every construct feels different to me when I fix these. I have to really attack um, with a thought process in mind about the goal of the surgery and the balance I'm trying to do. The skin is always a little bit of a concern, especially if they have additional factors that may make them have healing issues, such as, diabetes or some type of other chemo medications. I've also seen slow down the healing process. Anything that's if they're on immune suppressive type medications, I'm always thinking very thoughtfully about, less is more in some cases. Like the less the incision, even if I'm
Absolutely.
not getting the perfect reduction, what is my ultimate goal?
Absolutely.
Kind of
Yeah.
getting them back to walking and mobility seems for me to be the highest priority. All my decision making, at least in this patient population, seems to be around how quickly can I feel safe to let them mobilize, walk on it.
Absolutely.
Is top
Yes,
of
I
mind.
100% agree. And, in young patients, we worry about a perfect reduction and, making sure that everything is perfect and the ligaments are healed perfectly, to help prevent arthritis, right? In an 80-year-old, the goal is completely different. I agree completely. It's getting them mobilized. I am more likely to use like syndesmotic screws versus kind of suture button or more flexible fixation to fix the syndesmosis, because the main risk with screws, or the concern with the screws across that joint in younger patients, is that it can break and that it's malreduced slightly. But it's definitely stronger than the suture buttons and the suture type of implants. And so I have a low threshold to use those in these patients, because I think it's more stable. It helps prevent complications like recurrent instability. And a lot of these patients have neuropathy and things like that where they maybe can't quite feel as well, and that makes them risk for recurrent instability. So low threshold to use strong fixation
Yeah,
for ligaments versus just relying on soft tissue repair. Absolutely.
yeah. And I think I've definitely transitioned my practice to more um, suture management for syndesmotic type fixation, except for I still get a little bit nervous because the bigger problem is you're drilling a big hole and you're filling it with suture, which is a stress riser in the bone of someone who
Yep.
may have decreased bone quality. And so for me, I always, I have, knock on wood, haven't had a lot of complication. We have had a few patients that have fractured through that drill hole site. So to me,
Yep. I've seen that too. Absolutely.
conceptually,
Yep.
yeah, putting metal into that space, whether it's about the suspensory fixation or not, to me, I'm avoiding the stress riser is high priority. Um,
Absolutely. Yep.
so it's about, any most of when we think of open fractures, we think of high energy, we think of like, motorcycle accident, kind of big problem. But the literature really does demonstrate that uh, almost 25% of open ankle fractures are in this geriatric population. And, their soft
Yep.
tissue is just very, very different. I know you've definitely had those big transverse incisions that are, we see with the open fracture that makes healing. It's not so much the concern about the healing of the bone anymore. It really is about that kind of soft
Soft
tissue
tissue.
thought
Yeah.
process. So how do you
Yeah.
approach an open ankle fracture like that?
Yeah, so kind of same principles as all open fractures. Like you said, often these are almost like skin tears associated with an ankle fracture, whereas it normally, maybe wouldn't be an open fracture in a patient with a healthier soft tissue envelope, but it becomes an open fracture because of this. So, same principles as always. Clean it out, put an external fixator or stabilizer on it, and let the soft tissues calm down. We have a great wound team here, and so I get them involved pretty quickly, and they have a lot of what I'll call wound magic. So they help me manage the wounds, and they see them on a weekly basis, and they debride it, and they put all sorts of dressings, silver, all sort of things to help with wound healing. And then a plastic surgeon is involved in that clinic. And so if I need assistance, then they're there and they're ready. So I try to get these patients plugged in with our wound team pretty quickly, and they kind of help me decide when surgery is safe. And these patients are very, this is when I really use a lot of those percutaneous methods if possible.
Mhm.
And I think that's definitely a strong indication for the minimally invasive
Mhm.
option.
Yeah, I think it can't be overappreciated enough that this patient population's soft tissue behaves very differently. So I'm
Yes.
never surprised if they come in, even if it's closed, but they're swelling very quickly. There's this really important time frame and even type of incisions you make in that early process because I want to get immobilizing. I try to avoid an X fix whenever I possibly can, but I think that there's certain people that you just like you can almost predict within 2 or 3 hours you see these fracture blisters evolving. I think
Oh yeah.
teaching our residents to appreciate that is really important because I think that they're often really surprised how quickly, like 3 to 4 hours, it may have looked really great, and why it's important to do a skin check before you take them back to the operating room, put them to sleep, and realize that they have big fracture blisters in the space of where you're going to go. And so,
Yeah,
you know, even to
absolutely.
our
Well, on the same vein, I had a patient just recently who was, he thinks 67, somewhere between 65 and 70, morbid obesity, diabetic, on, chronic renal disease. And he had just a simple lateral mal, but displaced, and his ankle is dislocated. So he, definitely ripped his deltoid and the syndesmosis, all those ligaments. He was splinted for a week. I think he was admitted, and then I got to him the next week, but took the splint off in the OR, and he had a superficial abrasion to like the anterior shin, and it turned into this awful cellulitis, like
Mhm.
terrible, where we had to then X-fix, and so that he could get wound care and get treatment for that before I could come back and stage it. So I think on the same vein, as avoiding X-fix when possible. Sometimes I think it is necessary when there are wounds that need to be managed, and so it's always a tricky balance of
Mhm.
um, you know avoiding big pins into osteoporotic bone and a big external fixator device that can cause falls, and causes a whole other slew of issues, and splint immobilization where you don't have eyes on the wounds at all times.
Yeah. I mean, I think what I can't emphasize enough to like our multidisciplinary partners when I think about it, or even our residents in the teaching process, like every ankle fracture, I'm on high alert. Like I'm thinking like there's not a lot of things that we get concerned about the skin like, around the knee joint with tibial plateaus, for example, is another one. But
Sure.
there's not a lot of surgery that we feel like we have to hold up because of the skin too often. But the ankle is the classic location, and it will
The ankle should be it.
slow the
Yeah,
patient
absolutely.
down really drastically should they have any of those signs of skin that doesn't look like it's ready.
Yeah.
And an infection near the ankle can be catastrophic. I've definitely
Oh,
seen a handful of
absolutely. I
people
mean, that would
end up
be,
in.
that's one of the main things you want to avoid in these patients is infection, wound healing complications. Absolutely.
Mhm.
On that same vein, we always discuss, when to fix the posterior mal, when to not fix the posterior malleolus. Um, I have found in these patients, the posterolateral approach, which is a common approach to fix these really big posterior malleolus fractures, that incision always takes longer to heal in anybody, even a healthy patient. I hate that approach. It's necessary sometimes, but I really hate it mainly just because I know the wound's going to take longer to heal. And so I avoid that incision if at all possible in these patients. And
Me too.
for the posterior malleolus, I will often just kind of close reduce it, or use a device, use a freer or something through my lateral incision to reduce it, and then put an anterior to posterior screw or two across it. So I avoid that incision at all costs for wound
Same. Yeah.
healing,
Yeah.
for
I've
wound healing concerns.
gotten a little bit more comfortable, but it's definitely a little bit trickier to take a posterior screw like a P to A screw. If should I feel like I really need that,
Yeah.
compression at that fracture site. But I couldn't agree more. I think that it doesn't matter the age of the patient, that incision
It
just
just,
takes longer, it's more
yeah,
painful. They get
yeah,
closer to complex regional pain syndrome sometimes. So
exactly.
definitely, the balance of best fixation versus, like ideal state and pragmatic state is
Yeah,
something that really comes top of mind for me in those type of patients.
yeah,
I want to
absolutely.
ask a little bit more about so weight bearing and bracing afterwards. You know,
Yeah.
um, Tell me a little bit about your decision making for when you are letting these patients weight bear.
Yeah. So all patients get, 2 weeks in a splint initially, after surgery. Let soft tissues calm down, let the wounds heal. A lot of my decision making at 2 weeks is what their wound looks like.
Hmm.
If it's still not healed, then I will cast them for 2 more weeks, just to get the wound healed. Because I think, getting the wound to heal is number one priority in that post-operative period.
Hmm.
Because if that doesn't heal, then it's, can be really bad for the patient and lead to a lot of complications. So at least 2 weeks in a splint. If it looks really good at 2 weeks, then I will put them in a boot, and let them start ranging their ankle and let them usually I let them start kind of progressive weight bearing around the 3 to 4 week mark. But I've just found, I think that having these patients in a boot versus a cast is a lot lower fall risk. And I always tell them, like, look, your ankle's stable enough. I would rather you put a little bit of weight on it than fall. So I'm like, it's strong enough. Like, you just putting some weight on it is not going to damage it.
Hmm.
So and again, a lot of this depends on the fracture pattern, and the wound healing and the specific patient. But I'm pretty aggressive with my weight bearing. And I start what I'll call just like a crutch wean, where you're slowly putting more and more weight on the foot over a 2 week period with a walker, or crutches or whatever they feel comfortable with. But I get them moving pretty quickly, and then I'll often keep them in a boot until around the 6 week mark, and then let them get out of the boot. Braces, I honestly think a brace is more useful just for swelling. I typically recommend like a compression sleeve brace. The whole goal of fixation in my mind is that I don't need a brace, or don't need something that could
Hmm.
potentially cause a wound issue for them. But I'm pretty aggressive with my weight bearing, and again, I think I have the patient population that I can do that with here. That certainly wouldn't be the case for every single patient. But I'm pretty fortunate in that, and then I get my patients moving pretty quickly. But all of it for me, rides on how the wounds look at 2 weeks.
Hmm. I'm pretty similar. If I felt really good about the fixation, I will let them start weight bearing as tolerated. If I feel like if I can safely get them into a fracture boot at that point, if their swelling's even not ready at all, I don't. And even then, I try to make them keep the boot like a cast mentality, because what I
Yeah,
see is the shearing when you take the boot on and off. And as much as I would love to let them ice and range of motion their ankle quickly, I get very nervous if they're taking the boot on and off too much, if they don't have good healing of that incision, because that shear is
exactly.
really
Yeah.
problematic. So that 2 week visit for me is so important for the wound check, to making sure that we feel like they can make that decision. And I've definitely had the patients that are still so swollen, I don't feel comfortable letting
Yep.
them progress. I think too much swelling puts too much tension on that incision. It's going to cause wound breakdown, and so it's
Oh yeah,
balancing that, getting them walking.
absolutely.
So interestingly, though, I think a little bit differently with some of our dementia patients, the patients who have really big cognitive issues and aren't going to be able to, follow any
Feel.
guidelines that we give them, right?
Yeah.
Um, I have, I do worry when I put patients in a fracture boot, for example, how heavy it is, the off balance it puts them in for walking. I don't think it's a benign risk. So when I have patients who are like very simple ankle fractures or very even just kind of like moderate sprains, people are quick to hand out fracture boots these days in the emergency department, and I'm the first one to switch them to a. I try to get them into an ankle brace, especially if I didn't
Oh
fix them,
yeah.
because it keeps them on balance. It
Oh yeah.
gives them a little bit of I think that mental protection. That's my real reason for bracing, honestly. It's not that I don't believe that they're not ready. It's that I think I live in, where it snows, and so weather dependent, and if it's really icy, it's like I feel
Oh
like
yeah.
they actually were likely to fall and have a different injury if they don't have some type of like mental protection. So I tell them, bad weather wise, it's okay to crack this out. you know,
Yeah, yeah,
you're
yeah.
around your
No,
grandkids or your pets, crack it out like as
yeah,
a safety
yeah,
mental
totally.
break.
And I use the brace a lot for my younger patients for that too, for sprains or recovering from surgery. I'm like, hey, like if you're going to be out of the house and like, on an uncertain territory where you can injure yourself again, wear the brace to remind yourself and to remind other people. I think that's a great indication. I mean, and I've successfully in certain situations, like you said, patients with dementia, I've who can't tolerate a boot or a cast, I've certainly just put them in a brace. And I think that's a very useful tool to have as well and a useful indication for that.
Hmm. Hmm.
I just
Um,
get nervous with bracing patients after surgery, depending on their wounds. I've just
Agreed.
found that sometimes it rubs on the wounds and causes them
Friction.
to be
I
irritated.
I
Yeah.
always show them that it's important to wear a sock. Even all the visuals you see online, like for some reason they have ankle models who are wearing not no socks. I don't understand.
I
That
don't
is,
either. I
yeah,
know.
it's a
Well, and how
critical.
many patients come in not wearing a sock with a boot? So
Yeah,
many
yeah,
people come in and there's nothing between the skin and the boot. And so yes,
yeah,
it's a lot of patient education. Yeah.
yeah, yeah. That's great. So we're kind of getting near time. I just wanted to, thank you so much for everything you said, and see if there's anything else you just want to provide for closure when you think about geriatric patients that you didn't necessarily get to bring
Yeah,
up today.
I would say just, I really try to get the family involved. I always know that these patients are going to require a lot more of my time, and just talking with the family members and making sure they have a good support system. I wish we could send all of these patients to rehabs after surgery, but the reality is most of the time insurance won't cover it.
Hmm.
In my experience at least. And so, I have, my nurse helps me a lot, but we talk about, do we need to get you home health care set up? We need to make sure you have a shower, stool, walker, wheelchair, just all of the things that are going to help them get through this. So I think just getting
Hmm.
everybody on board early on, and talking about like, hey, like, you're not going to be able to use crutches. So what else are we going to use? A knee scooter? Are we going to use a walker? What are we going to use to protect you? I think talking about all those things that, young patients can figure it out, right? They can use crutches, no problem. But these
Yeah.
elderly patients really need a lot of help with this. And I get them into physical therapy really quickly, to try to just to help with that, with balance and transfers and all of that.
Hmm.
So that's kind
Hmm.
of the one last
Yeah.
point I wanted to make.
Yeah, great point. And actually, it kind of reminded me of one last thing. Timeline for healing of these. What is your kind of expected timeline, and does that differ from a younger patient?
In terms of like complete healing, like back to normal, sort
Kind of,
of.
kind of when you feel comfortable saying you're doing really well. Um,
Yeah, I mean, I think the 3 month mark is still, I always tell patients, say it takes bones 3 months at least to heal. I think by 2 months, if their wounds are healed, I'm feeling pretty good. I'm like, okay, it's stable. Let's get you moving. So I think 2 months is kind of 2 to 3 months is the window that I look for.
yeah, that sounds about right for me too. Well, I just really want to thank you, Dr. Jamieson, for your time today. Great
Yeah, thanks for
discussion.
having me.
Always great to hear how, everybody's thinking differently about these patients. And I think most importantly, if I were to emphasize one thing I was thinking about today is like it still starts front of mind mobility, quality of life. All of
Yeah,
our decision making needs to kind of center around those concepts, what and like co-decision making with the patient, like really what are their goals to get back to, and so that we can really adopt a patient-centered approach to things. So, well,
absolutely.
thanks again. We really appreciate it, and I hope you have a great day.
You too. Thanks for having me.